crystallize it, look at our takeaways, ensure that everything is encapsulated as we have discussed over the past 2 days. We ask that you grant us wisdom, you grant us understanding, grant us insight, help us to take decisions that would protect the health of the people of this country. In Jesus' mighty name we pray. Amen. So I hand over to Dr. Vanutu. We have 96 people online this morning. We've had very active participation from our online participants. It looks like it's here to stay for our health summits to do in person and online. Dr. Vanutu.
Yes, thank you very much. And I like the bow tie.
Thank you very much. That was by a popular request.
Thank you so much. And as you rightly said, I think it's come to stay. Now, those of us online are even more than those that are in person. So we can appreciate the support that we have received. Today is the third day, and the first 2 days have been great. I believe that the organizer and the ministry are really happy about the turnout and the discussions that have gone on so far. Talking about health information, in the past, people who were health information officers, I believe, saw themselves as maybe not that important for some of them. But these 2 days have shown us that that is not so, because a lot has gone on, so much. And I'm sure that those of us who have participated from day one might have also gleaned a lot from what others have said, supporting health information from different angles, not just in the health sector, but beyond. How can others be involved in taking this forward? And the theme, as it tracks health information towards UHC, has been very good, and also at a point where the health sector medium-term development plan is being developed again, and as the country moves on towards leaving no one behind, I think that a lot has been said and we have learned a lot. Some of us joined at different times and therefore might have missed some of the discussions that have gone on. So we're going to have somebody tell us some of the discussions, what are some of the key points that we have received, and what should we take away? Take away not just because you are going to put it somewhere, but you're going to work with it. It was exciting listening to the teaching hospitals talk about the way the light wave is helping with their work. One of the things that for me is very good is the fact that now they can trace clients' history. The client doesn't have to move with the paper. And when you go to the pharmacy, they know in the consulting room or in the laboratory. These are things that are good and will help us in our accountability of the clients that come to us. So there are other takeaways which individuals may have written for themselves, but would like to now call on Mr. Christian Osei, who is the lead rapporteur, to give us the key takeaways. Before he comes, I would like to welcome everyone online. We have regional directors, we have IPs, we have GPs, we have people in the hospitals from very far away. Some of them, they try to join, they go off, they join again, and that is commendable. We have community health nurses, we have midwives, we have from the teaching hospitals, we have from the health training institutions, the academia, universities, UHAS, all of them. We are very grateful and we welcome all of you to the last day of this year's Health Summit. So, Mr. Osei, if you are ready, I would like to call you now to give us the key takeaway messages.
Hello. Thank you very much, Dr. Linda Vanutu, for the insightful remarks. Okay. The Minister, the Chief Director, Director PPME, Director MNE, all directors here, honorable members of Parliament, DPs, all protocol observed. My assignment here this morning is quick and brief, is to just give us an highlight of all that we have done since the first day, especially those that were in one way or the other. So we shall look at some few updates on what happened on the first day. Of course, the first day was mainly on the holistic assessment, but there were certain accessory secondary issues that were discussed. And on the second day, we tried to break out into the various sections to look at the various categories under this health summit. So without much ado, okay. Of course, the essence of all health information systems is to produce data. How do we analyze this data? How do we disseminate this data? And of course, how do we use it for the effective benefit of the people or all stakeholders involved? And that is all that we are looking at. And that's why we have all gathered here to share ideas, discuss, brainstorm, and bring out the necessary details that is needed so that we can have a very resilient and robust health information system here for Ghana. And of course, Ghana has always stand out to also so that we can replicate it in other countries where possible. So after 2 days of insightful discussions and deliberations, what are the key takeaways? Let's start from day one. For day one, these are some of the issues that we were able to pin down. In terms of the health information system, one, there will seem to have, there is a lack of policy framework for the health information system that we have here currently in Ghana. Of course, the existing systems are not really built to provide real-time data and analysis, and this has called for a lot of discussions around this area. From the discussions that we've had, we've heard of GILMIS, we've heard of the LIMS, we've heard of DIMS, it's also there. So we seem to have some level of systems in place, but we realize that these systems are quite separate. So there's this multiplicity of data platforms across the health sector. So it's like we are doing something, but the question is, how do we amalgamate, how do we bring these things together? And therefore, we need to prioritize integration. As a matter of fact, there's also the need to prioritize the inclusion of non-service data platforms, which includes GILMIS, HRIMs, GIFMIS, and the rest. We also realized that there is low use of data at the lower levels of the health facilities, right? Those are the chiefs, health centers, and the rest. They rarely use the data that we have. We've also been told that about 15% of the data in the DIMS were from the private sector. The question now is, how do we upskill them or skill them up into and make sure that they bring in all or most of the information that is data that is needed to ensure a robust DIMS. Therefore, the private sector and quasi-government health sectors are very necessary or very essential towards building a very resilient or robust health information system. Other issues that came up were the issue of investment and scaling up of ICT infrastructure and logistics. We can't have a resilient or a strong health information system whereby there is lack of investment in terms of human resource, investment in terms of infrastructure and logistics. So how are we going to train up the human resource that we have? Are we going to build up their capacity? How are we going to provide the necessary logistics that we need, the computers, the Wi-Fi's, and all these things in place? These are ingredients that are essential towards building a very strong information system. I think these were key highlights that were coming up in the discussions on the first day. And then we moved on to the holistic assessment presentation by our director M&E, and these were some of the issues that were coming up. Of course, some of these issues came up last year. We thank God that we've been told that this is the last one for the 2020-2021 medium-term framework, and therefore we are looking at reviewing or reassessing the whole tool again. So this year is very good. At least we know that in the review process, they are going to consider some few things and make some modifications where necessary. So the key thing was the non-comprehensiveness of the tool in terms of what are some of the indicators. Are they still relevant? If they are not, how do we review them? If we are not going to review them, how are we going to take them out and bring in new indicators that can really speak to current issues or current developments as we move on? There were suggestions that we could also look at indicators such as budget performance, training, and other areas of infection control so that we can include it into the tool. And also include other cadres of health professionals into the assessment. The issue of geriatric services also came up, so we also need to understand data disaggregation in those areas. So for our those who are aged, what is happening? It seems the data is more focused, a little bit focused. The age categories are there though, but I think the tools or the presentations and the information we get is mostly on, is less on the aged. Last year it came up, this year too, it has also come up again. And Dr. Danu has made a passionate appeal that we really look at the denominator again. So this denominator, in terms of the population estimate, I think our director also explained nicely that, of course, these are based on projected estimates. And when the real estimates come, we can know how to adjust it. And they've accepted to review all those indicators where necessary. There's also the critical suggestion of a comprehensive facility health service that is needed to complement the service, what we are already doing currently. Day in and day out, we realize that we try to extract our data from DIMS. So the question now is, what are other complementary sources of data that can augment what we already have? So the reliance on institutional data such as DIMS needs to be relooked at again. We are also looking at strengthening multi-sectorial collaboration. Of course, this is the new norm. You can't do it alone. You need the participation of other sectors. You need the finance. You need the judiciary. Dr. Anefi gave a passionate appeal. I mean, we need participatory media, not media who just come and cover and pinpoint what we are saying, but media who come and participate so that when they are expressing their views, they can express the views based on the levels of understanding that is happening. We also need people like the judiciary so that at least there are laws and regulations pertaining to everything. And therefore, if we are looking at a trajectory of health information system, we need them to also give us a clear understanding of what is happening in the current dispensation. We also need to look at a broad-based approach in terms of not only institutional data, but what are the other indirect sources or other indirect effects, the environment, how best can we incorporate such indicators into the system. There's also the issue of policy awareness and education. We can do everything right. We can do our scaling, we can do our modeling, we can do our discussions, even as heads. How about those who are generating the data? How do they understand? How will they understand in the first place? So we need to critically look at making sure that all that we are doing here in Accra, those in Nyankpanduri, those in Waliwale, those in Bongo, should be able to understand. So policy awareness, education, literacy education in terms of health information is very, very key. There were other cross-cutting issues that came up, not necessarily related to health information system, but of course, because the assessment tool covers the whole spectrum of the health sector, we had to also discuss some few things. One of these things is to prioritize epidemic response programs and policies. Dr. Nefi made a very critical statement earlier on that when COVID struck us, our systems were not have not been designed to provide real-time data. So you can see those from Johns Hopkins were providing us real-time data. Those from World Bank was providing us real-time data. But Ghana, so we had to now streamline and then find ways to look at it. So in one way or the other, we can relate it to the health information systems to prioritizing epidemic response in as much in the direction of providing us a real-time data should this happen. We should also be concerned that there are growing cases of NCDs, TBs, HIV, and teenage pregnancies. And so therefore, all attention on COVID should also be really looked at, as we also bring our attention to other cross-cutting issues that are also pending and quite critical. We should encourage the investments in other areas beyond COVID-19. Also, we're also looking at health promotion. How do we facilitate enough funding towards health promotion? Family planning coverages. We have adolescent health clinics, but the patronage is very, very low. How are we going to encourage? Adolescent pregnancies or teenage pregnancy is quite high. I think Dr. Abuaji was giving us the estimate, about 12% of the population, almost close to 100,000. And the numbers are increasing. Just recently, it came to my Joy Online. The numbers are increasing day in and day out. How are we looking at it? There's also the increase in out-of-pocket expenditure by HIV patients. We may also have to critically look at the health service provision for the urban poor. Dr. Ankara gave us a very critical, he said what? It is the word slamization. Yes, that's the new norm that may be coming up. So it's not, we know the issue of migration. Migration is happening all right, but those that are migrating from the south or the north or to the south or from the rural areas to the urban areas, are they really migrating to the urban areas? Not necessarily, but if we do an evaluation or an assessment, we realize that they are actually creating their own slums in the urban areas. And therefore, we need to find ways and means to target them and then get the right source, the right data, and then assess their health conditions. Now, this leads us to day 2. And in day 2, what we did was to break ourselves into 3 groups and then have certain thematic topics in terms of infrastructure, governance, and then data use, capacity. So, of course, some of the issues that were discussed were cross-cutting. Some of the issues here were quite elicited in the other sections. So you may be finding some cross-cutting issues, but that is for us to discuss in our business in the next item on agenda. In terms of health data infrastructure, the architecture and interoperability, what were the issues? From the discussions that we've had with Gilmes, LIMS, DIMS, because of the multiplicity of the data platforms, we have all come to a very nice conclusion, and everybody agrees that there is low interoperability amongst the various health information systems that we have. We need to let them talk to each other so that we can have just a unit health information system that we can get or extract a particular information that we need at real time, at the same time, without any hurdles. We also need to set the rules for cloud system computing. Of course, everybody is now looking at cloud computing, whereby data is stored and you can always have access to it at real time. There are certain conditions to it. We are exposing people's data. Unfortunately, we don't have the servers here. Most of the servers are outside the boundaries of this country. So how are we going to ensure that there's privacy in the data, our data storage in the cloud? We also need to look at the digital health architectural guidelines. There need to be guidelines to define the digital health space that we seek to proceed or involve ourselves in. We don't have to throw technologies as solutions, as problems. We need to identify the problem, really diagnose the problem, see what is really happening before we come to look at the appropriate technology that can befit the problem that is happening or is occurring. We've also realized that people that generate the data or that input the data at our various low levels, health facility levels, they really need to appreciate what they are doing. Therefore, there needs to be an effective feedback mechanism. So if they give us this data and we are in Accra and we are assessing it and DIMS and we are providing health holistic assessment too, for those that are generating the data, if we don't give them a particular feedback on the data that they have generated, then they may not be able to appreciate the work that they are doing. They are the foundation of the data, and therefore we need to make sure that they understand, appreciate the worth of data that they are producing for us. So an effective feedback mechanism is quite essential. Other issues on health data infrastructure include collaboration with certain data generating agencies. These agencies are already undertaking data. In fact, some of them are the repository of data, especially Ministry of Communication, and then the telcos. They take all kinds of data on us. And therefore, as we move ahead, we should be thinking of collaborating with these institutions, and also look at measures to ensure the development of the right infrastructure in this collaborative area. There's also, as we look at health information system, we also have to look at two key important issues: data security and then backup and data recovery. In terms of backup and data recovery, the question now is, even the current systems that we are even using now, what is the backup strategy? What is the data recovery strategy? Even if there is data recovery, can we recover the data in real time? And how far back can we get the data? So these are the things we need to really look at. The other key pertinent issue is also on data security. There is an influx of cybersecurity all across the globe, and day in and day out, they are developing into new phases. The question now is, we've not gotten to that stage, but there is always an evolution of cybersecurity. So how are we going to match up with the current trends and even match up to the future with the future trends in terms of cybersecurity? So these are things we really need to critically look at as we move ahead. So there were some few recommendations from the health data infrastructure section or class. One is the issue of interoperability again. We need to have a comprehensive interoperability framework to define the standards. We need to set comprehensive standards for health information systems, and then ensure that as we are setting the standards, all other stakeholders, all other vendors involved must comply. Standards for all medical records, laboratory system, diagnosis, everything. Also, we need to establish the feedback mechanism, as we explained earlier on, so that those who are generating the data can appreciate the kind of work that they are doing, so that they can produce or input the right figures and then the right data, so that we can make rightful projections and rightful interpretations to our data. Training is very key. Building on human capacity is very, very key. We can't do without it. And also, make sure that we develop the right technologies to address the problems. The next is on the capacity to generate and use data. That was the second class, or the second breakout room. What were the issues that were identified? We looked at logistics. Of course, as I said earlier on, some of the issues may be cross-cutting because they all relate to the same thing, health information systems. So logistics are very key. The weak capacity of the low levels of health facilities, especially chips. Yesterday in our discussions or in our section, Dr. Ankra made a very insightful comment that a friend who had his child giving birth, the mother gave birth at a chief's compound, and then the other said, they were making an argument that she gave birth in a government hospital, so she is much more of a priority person, or much more valuable. The baby, I don't know whether it makes the baby more valuable than the other baby. So we need to really look at these things again. Okay, so in terms of weak capacity at the chief's level, we know that there are low capacity in the areas of births and deaths reporting, low capacity to certify deaths. Of course, we know that the births and deaths registry are now linking up their data so that we can have this with the Ghana card, so that we can have some of these issues addressed. So therefore, how is the Ministry of Health in the Ministry of Health agenda of making a formidable health information system, how are we going to collaborate with this new adventure that is happening, so that we can build this robust system to the benefit of our health sector? Also, we also need to look at the mindset of health professionals to adopt changes. I think, if I could remember very well, one of the chief directors of the teaching hospitals was making a very critical comment. And this even goes beyond the boundaries of health sector, the ability to adapt to change. Of course, whenever there are new developments, people are just unwilling to change. for fear of losing their jobs or for fear of the unknown. But we really need to move on because the world is evolving. We have already become a global village, and therefore we can't sit down at one place. So the mindset can be changed in one way or the other through training, capacity building, and so on and so forth. And then the disconnect between what is happening and then what is also happening at the academic levels. Yesterday, Dr. Jansa Lutrot made a very nice comment of the two academicians who were sitting close to each other comparing notes. And it's very important that they always want to come in, that whatever they are teaching, whatever they are producing from the field is what is really happening at the policy level. So how do we bring them on board, ensure that there's a connect between these two areas? We also looked at the difficulty in accessing data from the research institutions. Dr. Lutrot has elaborated on all these issues for us yesterday. The bureaucracies involved, the red tape involved, getting even ethical clearance from humanities, getting ethical clearance from Noguchi, getting ethical clearance from Kolebu, and so on and so forth. How are we going to ensure? Ethical clearance is just one. Can't we have a centralized system so that we can to generate an ethical clearance for somebody who wants to undertake research? There's poor quality of healthcare data, so we need to relook at the DIMS again. And of course, it's going to be reviewed, so we trust that things will improve, although we are doing very well. The lack of capacity to conduct facility health survey, we've already discussed that. How are we going to ensure that we scale up facilities surveys to complement the service surveys that we have at the DIMS? Data collection is already skewed to the service. We need to look at the non-service data like finance and the rest. So what were the recommendations from from the recommendations that were coming from here? Of course, if it's about management, we need to prioritize and involve these facility managers in the data management. They are handling the facilities, and therefore, as we engage them, they can be able to appreciate the worth of work that is happening, and therefore engage their staff to help produce the kind of data that we need for a resilient or a very formidable information system. Of training and the building of capacity of these staff is also very key. A common platform for teaching hospitals is ongoing with support from the WHO, and we know that if we should make the necessary adjustments, we can link it up to what we intend to do in terms of this health information system that we intend to build. The academia must not be left out. We need to create the awareness and enhance publicity. Make sure that we build capacity to gather mortality data. With the best and best innovation, we hope that this will improve. And also make sure that we are always collecting primary data. Yesterday, the government statistician, Professor Enim, was very strong, and he has always been very strong, even in the media, that we need to use secondary data. The data is already there. There are a plethora of data available. So we need to use them and get what we really want to do. Some of the data collection, we really don't need to go back to the field. The data already exists. We really need to use the secondary data available so that they will not go waste. Of course, if you go to other recommendations include expand data collection to cover UHC. We need to shift from data visualization to really answering the questions that involve data analytics on the UHC agenda. The focus of the health information system is making sure that we develop a system that can really, really address the objectives and then attain the goals of universal health coverage. Collaboration, once again, multi-sectoral collaboration is also coming up here again. The need to integrate into pre-service training, make data management more examinable in our institutions. We need to also build up our pharmacy informatics. I mean, these are indicators that are quite essential, and we have to look at them as we move forward in building a system like this. Of course, we also have to support the private facilities to build capacity in the area of health information. Dr. Dami, once again, because I was in that class, I can make references. They visited a facility in the Volta region. I mean, a private man is always a private man. His key objective is to make profit and not what you really want from him. And therefore, they went to him to ask him to make sure that they are producing data or get systems in place so that they can generate data into the DIMS. And he said that if you want us to do something like this, then give us the resource, give us the logistics, and give us the things that are needed, and we'll also do it for you. So they don't have time to waste their money on things that really don't directly benefit them. So therefore, if we can create some level of support system, level of collaboration of the private health facilities, it will be very, very key. The sector should be able to show, in terms of the next summit, what data has been collected to guide our operations. So it wouldn't be like a new thing, but whatever we have discussed in the previous years, let's see the progress of work in one way or the other. Then we can appreciate what is really happening currently based on what we discussed previously. We need to define policy framework and then revise the health information policy. The last group was on data governance. Data governance. What were these issues? When it comes to data, that is the foundation, that is the basis, and therefore data generation and its management is very, very, very essential, because it is out of the data that is going to be generated. It is out of this data is what we are going to use to make projections and make the various analysis and make the various policies. So if we do not put systems and mechanisms in place to generate the right data, then we are going to have a lot of problems. Data validation, data analysis, data use, and then also make sure that we make an investment in the infrastructure and human resource. We also looked at data security and risk management, access and control. Yesterday, Dr. Abuaji we all wanted to have a system in place where we can have access. He was also looking at a system, although we can have access, we can also look at the ways of generating some level of revenue from it. But data protection is also very key. Now that we have the data protection units, we can collaborate with them to make sure that whatever we intend to do, we do it well to generate a robust data system. Other issues was on data privacy. These are information on individuals, persons, and therefore we need to ensure that their data or the information on them is highly securitized in one way or the other. How do we protect them from all kinds of online attacks or all kinds of levels of confidentiality that may affect them? So we also need to look at these things very well. How do we share the data? Who are the custodians of the data? And so on and so forth. We cannot do this without policy and regulation, and therefore we need to make sure that policies and regulations are in place to enforce all the things that we are going to embark upon. This is to ensure accountability and provide the necessary feedback. We also look at data literacy, making sure that people understand the data that they are generating and then value the data that is being generated. We also look at data stewardship. Ownership of the data cannot be in the hands of just any other person. We are looking at making sure that the ministry ensures that they own the data, and therefore they can control it in terms of its access and usage. How is the data going to be used? What is the essence? What is the utilization rate of the data? We also need to look at all these things as we prepare to develop a health information system that is more stronger and more resilient. What were the recommendations? Of course, stakeholder collaboration is key. Building capacity of all data users is also very key. Making sure that we have the required policies and regulation frameworks in place to ensure that the system developed is quite robust to undertake all kinds of issues that may come up. We need to also invest in data generating infrastructure to ensure that we have a very strong interoperability systems in place, even with the existing data platforms or information system platforms that we have. People must also be aware that there could be incentives and there could also be sanctions. Where there are incentives, there should equally be sanctions for data breach. we need to also align and make sure that there's uniformity of the required data in data collection template. So whatever is being collected in the northern region shouldn't be so different from whatever is being collected in the south. Of course, there could be cultural and other environmental differences, but in terms of the general understanding and general data being collected, they should always be the same. And therefore, we are also suggesting that there should be an alignment of the existing data generating templates and then the policies that are being required. So basically, these were some of the key things that were discussed yesterday and on the first day for us to have a review of it. Thank you very much.
Thank you very much, Christian. Dr. Vanuatu.
Yes, fine.
Okay, so it's time for participant feedback. Any feedback from our online participants?
And let me commend Christian for a very good work done. And for everyone, because sitting back and listening, you realize that so much has been discussed, and we thank everyone for your input. From the online participants, talking about the involvement of all, the private sector has been mentioned, and Dr. Aminote Hansen would want us to be informed about the MOH and Private Health Sector Alliance of Health, that's the PRISAC, collaborating to hold their second Private Health Sector Summit on the 15th and 16th of June at Labadi Beach Hotel. It will be a hybrid thing, and more information will be coming up soon. I think I'm looking at what has been discussed about bringing on the private sector, not just the medicine and dentists, but about every private sector, the laboratories and the rest. So this will be a good place to also discuss more about how they can generate the information that we need. Now, somebody is also saying that they should look at the ambulance service and how they can be supported to have a pre-hospital information management system that can be linked to the DIGS. And then another person is talking about how the ear and hearing care plan can be revisited so that they can have a complete thing and get it going. Now, another person is looking at how the private sector, so yes, we have the private sector and to be engaged. So yes, these are some of the comments from the online participants. Some wanted to have access to what has been presented, but that is being shared, so they will have access to it. Kwame, back to you.
Thank you very much, Dr. Vanuatu. So we'll move in person for any feedback. Okay. Yes, sir.
I just have something to add. The private sector and the ministry. There's something that is lingering as I go on commissioning some of the private sector institutions. And I've been thinking about how we can come together. This summit has just given me, just what I heard is that brought me back to that issue. The ministry, through their regulatory agencies, HEFRA, gives permits and all those things to these private sectors. They required at least a physician assistant to man, some meet doctors, but it's a lengthy issue that I've discovered, that the health insurance card they have, the private sector they are not utilized. You go and you go, if you have your insurance, they will not accept your insurance card. And I don't seem to understand it. Because is it the facility or the human beings? Because if it is the human beings, we all pay taxes. Why would I go to Kolubu and my health insurance will be accepted, and when I go to my dinner clinic with HEFRA, permits and everything, where, and they say, no, Alaji, you can't benefit from this. So that summit, this summit should look at it. If there's a good data, then we can do the analysis and linking the whole system. If it's a policy that we need to expand most of the revenue that will go to the national health insurance to cover all these places, I think we have to think about that. Because we are discriminating. And the reason why we have problems is that we are not able to integrate the data properly. So you have to think about that. So that somebody cannot go, you can go to different facilities and you look like there's no connectivity. Oh, the man has been going to Medina, then yesterday he went to Medina, today he's going to this other part of the system. So I want the summit and the ministry to look at the private sector leakage that we'll be thinking about so that all these nitty-gritties can be ironed out. Otherwise, it's embarrassing. You go as a minister, you open a facility that is sometimes more powerful. The facilities are even more powerful in the government hospitals. And the people will tell you that if we come here, they will not accept your health insurance card. Mr. Moderator, thank you. I will take permission to go to the National Conference Hall. We are having a program there. Thank you very much.
Thank you very much, Honorable Sain.
So I leave you. Have a fruitful deliberation.
Let's take Dr. Okay.
I think that I want to thank the comment from the private sector, which is very unique. My recommendation will be that before we get to Health Summit, we normally will have held the regional and the district reviews. And so in future, as much as we are very open to working with the private sector, it will be very helpful if the private sector summit takes place before the annual health summit so that the decisions can be collated and we can all sign the memoir to ensure that what the decisions are, we are going to implement. This will be my suggestion to the private sector. Thank you.
Thank you very much. Yeah, Dr. Aziz, just a second.
Thank you very much. I think my observation is that I may be missing it, but what hasn't come out forcefully is reliability of data, reliability. I haven't seen where we underscore or state the characteristics of how reliable data is, because data can only be usable if it is reliable. And so that element, I think we have to revisit that side. Then my contribution to how do we get data from private setup. Now, getting data or asking data from private setup is like asking citizens to pay tax. They don't see you as a participant in the generation of their income. And so if you ask them to pay tax, then it becomes problematic. So why don't we design, as part of the approval for their operations and for the renewal, so that to be part of the condition that you must be providing data to the national data receptacle. Otherwise, your renewal will not be guaranteed. If we do it that way, maybe they will be obliged to provide the data. Otherwise, willfully, I mean, like somebody responded, if you haven't given us logistics, why do you come asking us to provide you data? When we have used our resources to set up an institution, then you come following us to provide you data. So the other way around it is to make sure that we put it as part of a condition to approve or renew their license to operate. Thank you.
Thank you very much. We'll take the taxis, then we'll come to you. Please come.
Anyway, thank you very much. I am from quasi-government health institutions. In the past week, I considered private, but we are not private. So I want to declare that we are not private. We are government institutions whose mandate are not healthcare delivery, but who are offering health service for the people of this country on behalf of the Ministry of Health. So we are not private. But because of the peculiarity of our positioning, in terms of funding, in terms of administrative arrangement, we seem to be operating before the health insurance a different revenue packages that is separate from the mainline health services. But with the advent of the health insurance, we seem to be aligning to the government policies such that our charges, our revenue flows are in tandem with the law establishing the healthcare delivery in this country. Nonetheless, we have been giving data willingly, voluntarily to the health services. But what we are worried about is over time, over the ladder from CHIPS compound to all the cadres, our names disappear. So when you are accumulating the national data, even we might have given 100, but by the time you get there, it's about 20. Because some of our facilities serve as the main district hospitals, and therefore their data is considered as Ghana Health Service district hospital retains. Those that are lower down, the data just goes in and fizzled out. By the end of it, or as quasi-government health institution, we don't have a national data that is attributed to our membership. So we are trying to make a passionate appeal to the national body, to the regional body. We are doing it individually, but we want the summit to recognize that as much as we've been giving the data, and we'll still continue voluntarily give it, let us also give. Let's be in academia, you must reference appropriately. Let's reference the sources of the data appropriately. Don't let it fizzle out. VRA issued their district hospital completely, their name doesn't come out as quasi-government. It just fizzled out as if it's Ghana Health Service. So with all apology to DG, DGD is benefiting from our hard work. The Director General for Ghana Health Service, you are actually enjoying the benevolence of quasi-government health institutions because some of us serve as district hospitals and facilities. So our data just goes in as if it's Ghana Health Service generated data. So we want to start with your help to collate those data from the sub-districts, district, regions. When we are submitting data on regional reviews, we'll say this is from quasi-government. We are not private. So in the past, you are linking us with private. We are no longer private. We want to declare and make that distinction that we are not private. We are part of government, but we are quasi-government. And then whatever there are any booty, which we are already enjoying, but going forward, we will continue to enjoy. But we don't actually rely on the booty. We are coming on board with something to offer, which we have been offering. Secondly, I want to add that what to make the data become useful is making sure that the original data is okay. And there's no way, like somebody says, there's no way people willingly take data and give it out. What we do in quasi-government is to make sure there are different levels of supervision at every level. The person taking the data is being supervised so that the data you are generating, you know that you are answerable. It's not like you'll be answerable to it in next year. Immediately, at the end of the day, somebody monitor what data did you generate today? What data did you generate an hour ago? Did you ask the person's age? This person you say is 20. Meanwhile, the person is about 40, 50 years. And you all know that even the biodata, the interpretation of the biodata with respect to healthcare delivery is vital. You don't just assume that the person is 20. If 20-year-old person has CVA, the difference is, the interpretation is different than somebody, a 60 or 70-year-old having CVA. So the person taking the data must know why he's taking the data and how, if you interpret the data, the implications of it. So don't arbitrarily give age. And the same thing, don't arbitrarily give even where you are coming from. If I have 20 people having diarrhea disease coming from Jamestown, it's more important than having 20 people, some coming from Tamale, some coming from this. Or even from Jamestown, one household having 20 diarrhea cases. So when they say, where is the person coming from? Don't say, oh, I know he's coming from Medina, when that is not actually the case. So those are just biodata, making sure that we get the right data at the right time. As somebody said, reliability, to be able to make an informed decision and policy directive. That is our submission from GACI. Thank you.
Thank you very much.
Good morning.
A
couple of
people online. We have some more comments from our participants online.
Okay, Dr. Vanutu, that is noted. We'll take 2 from here and then we'll come online. Thank you.
Couple of points. Wanted to just mention the importance of connecting technical schools to developing micro programs around software and data collections. I believe that some of the brightest minds are sitting in some of the technical academic institutions who are creating software that could possibly be used to help facilitate the health information system. Also, it would be nice next year that the presentations and the videos and some of the other stuff being shared be put on the Health Summit website, so that those of us who may have to leave early or want to access those presentations can download them, as opposed to having to wait until real-time presentation. Next, that a work group be considered to, someone mentioned yesterday, data sets, being able to sell data sets to pharmaceutical companies and others, that this be looked at as a revenue generating part, because there's a lot of data in Ghana that is sitting on the shelves that has a certain value to it, to other countries and other companies and corporations that are in the country that should be considered. Dr. Eric, you know I have to insert the need for the donor partners and the government of Ghana allocation being reduced, and how that is going to be reflected, perhaps as a special note or something in the final holistic report, so that people can see this is the donor support that's come in and the decline. This is how it matches up with the government of Ghana allocation decline. And then lastly, I believe I'm saying it right, the themes system, is that for those who are working on that, is that coming from the U.S., there's a way for me, when I go and take tests with my doctor, that I'm able to send a message over a secure network to say, what are the test results? If I need a prescription for anti-malaria medicine or something like that, is that can the theme system, if not, it may already be there, Kwame, that the patient, there be a patient portal to be able to communicate with the healthcare provider to ask questions, so they don't have to physically go to the facility, that they can have this exchange via a secure online communication portal.
Thank you very much.
Thank you very much, Kwame, and a very good morning to all of us here. I think from the presentation that was done earlier this morning with the summary, which I'm sure is going to the memoir from this conference, so much has been learned. My worry, however, is to do with specific action points. And this is where I want to advise that beyond this, and you realize that this constitutes a summary of some of the concepts that has come up, the challenges and the recommendations. For instance, HEFRA has been mentioned several times, but it's not just HEFRA. The teaching hospitals, Ghana Health Service. What are the lessons from this conference? What are the challenges that we are living here with? I think that the team that has put these reports together should develop specific action points for these specific agencies with timelines, for which we said that, okay, for the next 12 months, what do we expect these agencies to achieve? So that by that time, as part of the PPME's evaluation and monitoring, we will see how much we have been able to achieve, especially as far as the focus of this year's summit is concerned. I think it's very, very critical. In that way, we will see that we are making a forward move. In fact, we have mentioned about resources, finance, and what have you. But I believe that for even whatever we have today, there exist some opportunities for us to do budgetary alignments and some new commitments and make sure that the focus of getting the right data in terms of validation and data usage, we are actually achieving something. The other thing is to do with the ownership and then the usage. Sometimes I get worried because even with the coming to being of the electronic medical record system, thanks to the intervention from LEMS, annual performance reviews, I'm telling you, even from the teaching hospital platform, we meet and validating our data, we are still struggling. Meanwhile, the data has existed in the electronic platform for the whole 12 months. The question is that the departments in the teaching hospitals, the units, what has happened to the data over the period that come the end of December, we are struggling to pull the data. What it tells us is that those who are generating the data have no clue as to how the data is compiled and how the data is applied. So as a practitioner, how do you use the data that you yourself are generating? I always cite the example of where I did my postgraduate training, where at the end of every month, our data is there. We sit down with our boss. Sometimes we look at it and say, no, this one we didn't do well, this one we did well. And almost every month we're having parties. Because our head of department is happy that our numbers are going up. Because we have set ourselves targets for the year. And we break down the targets for the year. And monthly, first month, second month, third month, if you are going to meet the target, it will tell you. If you are not, this is where you learn lessons and look at your strategies of production and see that, okay, I think we are not doing well in this area, so let us do A, B, C, D. But the point is that even when the data exists, we wait till the end of the period, and then we are struggling to even pull the data from the electronic system. So I think data ownership and application, our practitioners, let us get the sense and the good culture that, look, we are generating the data, and the data must inform the way we work and to be able to improve the system. Thank you.
Thank you very much. Want to move online. Dr. Vanuatu.
Yes, thank you very much. It's good to see the passion with which everyone is talking about data. The private sector has come up strongly. And we have a comment from Dr. Letitia Apia, Executive Director for the National Population Council, who used to be the District Director for the Lejokuku Koron District. And she says that in that district, to get the private sector to collect the needed data, they assign national service personnel trained in DIMS to all facilities. This brings out another cadre of staff that can be used to support the private sector. And I think that the Ministry of Health, Ghana Health Service, have been working with the national service. So this is an area that the private sector can also look to. Now we have from Nish McCree from UNAIDS, and he says that he's congratulating us on the good work done, but related to HIV, in the next version of the holistic assessment, he's recommending that we disaggregate the data for pediatric populations, and that if we are to achieve the WHO verification of the elimination of mother-to-child transmission of HIV, we must more closely track the progress of pediatric HIV. That's an important point for us there. Dr. Salian Ohene, she says that ensuring adequate financing of HMIS also came out strongly in the discussion. So we should not talk about it as to how to do it, but what are the financial implications to get these things done. So Fonaris also says that the need to conduct a comprehensive facility study was one of the recommendations of Group 1. So the key takeaway messages can include that one. And then Esther Apia, she says that with the private facilities who don't have much interest in the entry of data into DIMS 2, she would recommend HEPRA to make it compulsory. I think HEPRA has taken steps to do that, for them to get someone to help them with the entry into DIMS 2. Since they are responsible for the renewal of their license, they can tell them that it is one of the main points they will be looking at before the renewal. So HEPRA has already started doing that. James Amewuda says the involvement of health information practitioners in some of these discussions has not been good enough, and can we scale this up going forward? I think that to answer that one, the invitation is actually open, especially for the virtual participation. So maybe in the future we'll broaden the sharing of the links. When you get it, to share with your friends so that people can participate online. Kwame, thank you very much, and back to you.
Thank you, Dr. Vanotu. Yes, sir.
Thank you, everybody. Thank you for the presentation. I think one key point coming out is that data literacy, data ownership is a big problem. And I think coming from GACI, coming from Ghana Medical School, coming from a teaching facility, I think part of the problem is that in our teaching institutions, we lay emphasis on just service. So in the medical school, I'm just taught anatomy. I'm just taught how to treat and cure patients. The non-service delivery part of it is never, I'm not told anything. It's never part of my concern. Procurement, logistics, radiology, I don't know anything. But as we go along the system, I become the manager of the system. I become a leader of the system. I don't have any concern. I don't know anything about what it means to the, if I'm a doctor, we are not interconnected because we are trained mostly in a teaching hospital. Where in a teaching hospital, we do things in silos. We do things in segment. Even the anesthesiologist that's having nothing to do with the surgeon. How can that be? But that's what happens in our teaching hospitals. So I think a lot of has to do with our training. I think we have to completely turn our trainings upside down. So that our training should be broad. Because we are not specialists. We are not trained as specialists, but we are trained in a specialist environment, and we are being trained as if we are specialists. So our broad base is not broad enough to take the pyramid, to take the system. I should be taught at the medical school. It's easier, the registrar is there. I should be taught about health finance. I should be taught about health social dimensions of health. I should be taught about health communications. I should be taught about the cultural issues, dimensions of health. I should be taught about the social dimensions of health. That's the only way then, when I become a manager, when I'm in the system, I can understand the value of generating a certain information when I come as a patient, and then we don't extend it to our schools. We don't extend it to do you believe that I will end here? A woman will come, or a man will come. I ask her, she's obviously 60-something. What's your age? I'm 26 years old. Because they don't value, the patients don't understand the relevance of those things. Where are you coming from? Who is your, coming from? He's coming from Medina. He says, I'm coming from Teshi. Because he doesn't understand the value of, like he mentions, in relation to communicable disease. Who is your next of kin? Just mention anybody. And I've done that. And it has to do with the people also at the records office. So I think we have to go back
to even our what, educational system. How do school have program? How do we teach? Otherwise, if you don't do that, the literacy and the ownership will continue to be what? A big problem. And once people don't have data literacy, then the data usage become an issue. The data, giving information for the data becomes an issue. People just mention things anyhow because they don't think it's important. So I think we need to even involve Ministry of Education, the Ministry of, chieftaincy and all those things with the community. It's only then that I think we can then have good quality data and then we take it from there. Thank you very much.
Thank you very much.
Thank you. Thank you for the opportunity. Just wanted to thank the ministry for bringing this together. A fantastic discussion around health systems data, what needs to be done. It's very insightful, and basically kudos to you for bringing this together in such a short period of time and in spite of all the challenges. I have two sort of thoughts to share. One is around the whole conversation around the data systems and the use of data, and one is around some of the observations from the holistic assessment. So, with your kind permission, my first thing is around, it's very laudable that we are trying to integrate the various systems that we have across GILMIS, GIFMIS, and all the other systems. That integration is essential, vital. But going forward, we also need to invest some thought and probably resources into creating an architecture, a digital architecture, a guideline to develop that. Going forward, what would be the nature and the configuration of all data systems? So you need a platform, basically some sort of guideline. As an example, should all future data systems be based on ComCare? The APIs need to be opened up in such a way that then at the back end, the data systems start talking to each other. You need to be prepared for the future. So we should actually work together to figure out whether in the next 6 months we can have these architectural guidelines ready so that the newer developments that come are ready for the future, right? So that's one thought process, a thought I have for us to process. Once you have these data, you also need some guidelines on how to use the data. And the use of data is what will eventually very closely link to the quality of the data. So as an example, if community level data is collected, how will the community health committee actually use it for improvement? How does the health system become more accountable to the communities it serves through the use of this data? So we need to have these processes in place. You can't wish them to be there. We've seen brilliant examples in the field in some places, but there have to be structured guidance around that. We should envisage a system by which you have district level dashboards, regional level dashboards, national level dashboards. You should envisage ranking of facilities, ranking of districts and regions, all through good use of data, and then you can reflect upon performance and then support those who require additional help vis-a-vis those who are doing well. So I think there has to be a thorough debate and discussion on the use of the data, and it's very critical you set this up before you venture down this path. Much has been said about quality of data, and we need to make investments to ensure that there are proper data audits. It needs to be built into the system. It can't be a one-off thing. So there has to be a cultural change of data audits and data audit trails. It's not to find fault all the time, but at least it gives you a correction factor that when you need to read the data, you understand what the errors in that are and then interpret it accordingly. So there is a need for that. And also, data gathering versus data generation, I look at it from a very different perspective. I have had the fortune and misfortune of seeing two systems where data was gathered, where the health worker client interaction was reduced to looking at a tab and keying in stuff, right? And the essence of their interaction was lost. And therefore you had a lot of good data, but really little healthcare being provided in that sense. But I've also been in a system where you have these old handwritten cards where you just tick off on everything that needs to be done, where I can still maintain eye contact with my client, and all of that is done. And then later on, that is just fed into a digital reader and the data gets digitized, right? So digitization for the sake of digitization should not be the end game of this. You shouldn't sacrifice the quality of interaction between a client and a healthcare provider just because you want to digitize things. So that's another thought I had. On the holistic assessment, we have a lot of good indicators. And if we really want to relook at a good mix, we should have a good mix of performance indicators and impact indicators, right? Everything cannot be about just maternal mortality, because that's so hard and so difficult and so time consuming to measure as well as to make a change in. But what goes into making that maternal mortality or reducing the maternal mortality, some of those performance indicators can be more assiduously tracked, right? And now we know what most of our challenges are. Our challenges are more around the quality of care, right? We are doing good as far as coverage is concerned, ANC, PNC, institutional deliveries. So maybe we can focus more on quality. That's where the essence of it come. I mean, from there probably more of the essential learnings would come out. And ultimately, so more on the holistic assessment. We also do a holistic assessment with the Ghana Health Service, and that data is also critical. So is there some way we can, use both of these together so that we understand better the gap between policy and implementation, right? Because ultimately the delivery arm is the Ghana Health Service, and how can we get both of these assessments talking more in sync to each other? Finally, the ultimate end game of use of data is how do you improve the health of our nation, right? And that needs, that has a lot of connotations even beyond. So we need the fiscal space to actually generate, the data that is generated is probably useful to increase the fiscal space that we need so that essential health and nutrition interventions can actually be implemented. So where does that linkage comes? Where does the accountability of the data at that level come in? I think these are tough questions we need to start asking ourselves right now as we embark on this journey. And finally, just say a big congratulations to the entire team here, the discussions. It has been fascinating and I think a brilliant discussion. So thank you.
Thank you very much. So I invite Dr. Asamoah to give us our last feedback for our key issues. Dr. Asamoah.
How many hours? Thank you very much for asking me to. He hinted me that I need to give some reflection, so I've written a few things down. And let me start by thanking you for making me part of this summit. I really enjoyed. My original plan was to come for a day, and I've ended up 3 days. And I've learned a lot. I've learned, for example, that many of the senior officials in the health sector are prayer warriors. From Bishop Inkansa to Reverend Asabre, he's not here, to Reverend Odami, Elder Nyante, Archbishop Anastasia. Very powerful. We praise the Lord, most gracious and most merciful. I've also learned, the minister is not here, that in his time at the university, he was the choir master of the Commonwealth Hall. You won't believe it. Now he looks so honorable, but he was a chief finder. But he told me yesterday that not only is he the MP for Doma, he's also related to the Doma Hine. Glass and Kwa. I won't be surprised if the Doma Hine also goes to Memphis to play golf. But when you are playing golf, you must dress well. Yesterday, we also learned about the Speaker of Parliament's epiphany. Yes. even though he's a former health minister, it was through his journey to Damascus, no, I mean Dubai, that he recognized that health is the most important. Praise the Lord. I have really been impressed with the level of participation. The minister was here the first 2 days. Alaji was here, he had to leave. The chief director has been here the whole time. Director General of Ghana Health Service. We've had all the CEOs of the teaching hospital, including even former CEOs. Rectors have been here all the time. Colleagues from the Kwesi government institutions, from the private sector, rectors, our colleagues from development partners. I mean, this is really very impressive. And it's made the discussion very rich. So thank you all for the participation. I've been really impressed. The MCs have been very superb. Linda is over 60 years, but she's not lost her energy and beauty. And Kwame has been very amazing. The last 2 days he was in his Ken Oforiates uniform. Now he's gone to Okuboy. The moderators have been very great. Prof. Adano, Dr. Lawson, Martha, the government statistician, I don't know whether he's here, to take part in our session is very great. I really like him. When he talks about inflation, it's less boring than it used to be. And all the presentations have been good. The lead presenter has been Dr. Isia Boatin. Thanks for the presentation. I noticed that the in thing now is white beard. So the new generation, they are not shy to show their beard. So I will pass it on to my senior brother, Dr. Kwabena Dufo. He's my brother, so I can say that. And the IT people have been great. Time management has been quite good. As long as we start, it gets better. And everybody has behaved very well. Even my brother, Dr. Atipu, has behaved quite well. I like his perseverance and persistence. Now we all know he was trained in Sweden and Finland. But I was blown over by the Minister of Health, Kwa. I think they've been very wonderful. Now we don't need to invite Legon Palm Wine Band or Ghana Dance Ensemble. My only problem is that when they were singing, there were no collection. So next time there will be Kofi and Kofi Nyama. My assessment of the program itself, I was very positive. I think the opening ceremony was short and straight to the point, so it's important that we keep that in mind. With the first day, the focus was the holistic assessment. So let me just give a little reflection on the holistic assessment. From my experience, presenting the holistic assessment has always been very tricky because you need to be comprehensive. Otherwise, people keep reminding you, you've forgotten about pediatric AIDS, you've forgotten about this. So there's a tendency to be very comprehensive. At the same time, when it becomes too long, it gets very boring. So I think the strategy to have the panel discussion is a very useful one. And maybe that should be much longer than the presenting itself, because it's not very easy to present the holistic assessment. So, but I think it is. The take-home message for me from the holistic assessment is that it served us very well. Hello? Thank you very much. the holistic assessment has served us very well, and we need to keep it and find ways of improving. And I think one of the ways of improving is what has been discussed even this morning, that we need to look at other data sources. At the moment, we are using data we collect ourselves, and that will not give the true picture all the time. So it needs to be complemented by other data sources. But I think the take-home message is we're not doing badly given what we've been through. So last year we did perform. But the big message is that we need to pay more attention to the demographic transition taking place. The fact that our figures for the urban and peri-urban areas is low is an indication that we need to pay more attention to urban health, given that the census is telling us that we are moving to more people living in urban areas. There are perhaps more people living in uncompleted houses, kiosks and containers than people living in residential areas. So we need to address that. The other thing that strikes me is, and you will not be surprised, is about the fact that our population is graying and aging. The number of 65-year-olds are increasing, and we need to pay more attention. Their numbers may not be that big, but they are also very vocal people. So if we don't take care of them, they will talk. I'm referring to people like Prof. Adai and who talk all the time. So, but I really enjoy the discussion, and I think, as everyone said, the discussion on the health system, health information system, and for me, this is one of the best discussion, even from my WHO days, on how do you dissect health information system. So thank you for the spirit and for the tone of the discussion. I think what also gives me a lot of hope is the consensus that came out of it, that really the system we have now is not fit for purpose. In the past, there's a tendency when you talk about these systems to say the problem is not the system. The problem is more money. You just give us more money and we can expand the DIMS, E-Tracker, so much. But what I got from yesterday's discussion and today's summaries, we all recognize there's a fundamental problem and we need to really address it. It's not just more money, even though money is very crucial, but it's not just more money. My little disappointment, and I voiced it out yesterday, is we're still not thinking big. And we're also not taking advantage of the many opportunities around us. And we are not taking inspiration from universal health coverage. So I just want to repeat that we are in the era of universal health coverage. Before universal health coverage, you could say our coverage is 80% and you are happy. In the era of universal coverage, 80% means 20% are not covered. So it's turning the other way around. 20% are not covered. And therefore, we are as interested in those who are covered as those who are not covered. Our health system now is based on service delivery. Those who come to our service, we collect data on them. If you don't come to our service, we don't collect data on you. And we are basing our decision on the people who come to our facilities. So we assume that because our number one OPD case is malaria, the number one illness in Ghana is malaria. It may not be true. The other thing is that we are not broadening the provider base. Most Ghanaians, their first point of call is community pharmacies. We are not using that information. Many Ghanaians go to healing camps. These are all providers, whether we like it or not, we should be collecting information from. And yet we just focus on our own. I'm very happy that we are now paying a lot of attention to the private sector. Increasingly, more people are using the private sector. And in fact, most Ghanaians don't discriminate between the private sector and the public sector. Today, they are in Yahoo, tomorrow, they are somewhere else, the next day. So for them, everything is the same. And I hope we'll get to the stage where those of us in the health sector will begin to see everything together. I was really disappointed some years ago. There was an issue about Bank of Ghana Hospital, And one minister said, they don't come under me. Bank of Ghana, every hospital in Ghana comes under the Minister for Health. It's not only Ghana Health Service or the people in this hotel. Everybody is under the Minister for Health. It's a hotel because it provides accommodation and food and auditorium services. So excellent. So I'm hoping that we will begin to look at the bigger universe, a bigger denominator. Our denominator, and I know Dr. Tipo is now smiling. Our bigger denominator is how do we get information from 31 million Ghanaians? It's not the 10 million who visit our facilities. And that is why it's important that we link up with civil registration, with digitization process, with the telecoms. So I'm really, really happy and impressed with the discussion. I won't go into the details. I think the recommendations provided by Christine and the others are very useful and very informative. My feeling is what we've done the last 2 days is more of brainstorming. We are not yet at the stage of actions. And I think the next discussion is how do we take on board all this rich discussion? How do we involve a lot more people than we've done in the past? And how do we then get to the stage of very clear action points? But once again, thank you for inviting me to be part of this. And I salute those who've been part of this organization. I know how difficult it is to organize meetings like this. So thank you, Dr. Odame and his team, and all those who've been part of it. I shall return. Thank you very much.
Thank you very much, Dr. Asamoah Ban. My information is that the people on the online platform are laughing their way. Their ribs are cracking. Thank you very much. It's always such a pleasure to have you here. Finally, we've come to the end of our program, and just as we were welcomed when we came in by our landlord, Asamoah Ban says it's a hotel, so I don't know what the designation you will give now. Want to call on the Chief Director to give us the closing remarks.
Thank you. Thank you very much. I thought Dr. Asamoah had given the closing remarks. So what am I expected to give? And most of the things I was going to say have already been said by him. Not, of course, including the ones that are making the people laugh. But being the landlord of this hotel, I will still have to let my voice be heard. The same way that my voice was heard when we were starting. But since we've sat down for 3 good days, we haven't rested, I'll go straight to what I have and cut out most of the things that have been said already. All the protocols are there already. So let me say that it is very, very exciting for me to deliver these remarks as we bring proceedings at the 2022 Health Summit, which has the theme Strengthening Ghana's Health Information System for Tracking Universal Health Coverage, to a close. And I am particularly happy for your active participation in this year's Health Summit, as it attests to your utmost commitment and burning desires to ensure that we achieve a high functioning health system that is accountable and able to meet the expectations of everybody in Ghana. Since our gathering here on Monday, we have listened and discussed the holistic assessment report of our sector for the year 2021 and some of the key takeaways or the main takeaway from the session was that the holistic assessment tool in its current state is not comprehensive enough. As for the details, I will not repeat them because many of the presenters have already talked about them. I'll be boring if I continue talking about them. There is also the need to prioritize the inclusion of non-service data platforms such as the GILMIS, the HRIMS, the GIFMIS, and so on. We also had 3 parallel sessions geared towards building a robust national health information management system for tracking our performance towards universal health coverage for Ghana by the year 2030. And similarly, some of the key takeaways from these sessions were that there is limited interoperability among some health information systems, and that there is a need to develop a digital health architectural guideline, and that there is a need to set up comprehensive standards for health information systems and ensure compliance by all vendors, establishing an effective feedback system for data collectors, and the need to promote collaboration between institutions and organizations involved in data generation. I think that the recommendations that have emanated from the various sessions are very pertinent and will be pursued aggressively by the Ministry of Health in collaboration with all the agencies, the development partners, NGOs, and CSOs in health, other ministries, departments, and agencies, the private sector, as well as all other stakeholders. In order not to bore us, let me end by congratulating the organizing committee on behalf of the Minister for Health for putting together yet another successful summit. My profound gratitude goes to our special guests of honor, Dr. Anafi Esamwaba, who, in spite of his busy schedules, has made time to stay with us from Monday till this time. Thank you. I think we really deserve that. And in the end, he has also delivered the vote of thanks by thanking all the participants. I also thank all the agency heads for their active participation in the summit, especially to those who had to travel from afar to the summit. Let me also thank all the moderators, panelists, presenters who played key roles in ensuring the success of this summit. I am particularly grateful to our development partners who supported us in diverse ways. I will not be able to enumerate to tell you the diverse ways that they helped us, but in all ways, they were helpful to ensure the success of the organization of this summit. And to our virtual partners, the unseen but heard participants, we say we are extremely grateful for your time and active participation, particularly Dr. Linda Van Otu, for the great work that you have done. I wish to end by encouraging all of us to continue to work together in the spirit of health in all policies and One Health towards the attainment of the best possible quality of care for better health outcomes for us all. From here, we are going to meet for an agenda setting and a business meeting to enable us put all the issues that we have discussed together and use it as a working document. I therefore declare the 2022 Health Sector Summit officially closed. I thank you all for your attention.
Thank you very much, sir. The Chief Director has closed us. Dr. Vanutu, we can hear your voice for the last time as I round up with the announcement. We can't hear her voice, please. No, she's not muted. We can hear you loud and clear.
You can hear me now. Okay. So if you can hear me, I said that Dr. Samama, thank you. Yes, I'm over 60. when Christian was reading the takeaway messages, he said the aged. We are not aged, we are elder. Well, thank you so much. It's been a pleasure joining this meeting. Last year was good. This year has been wonderful. We are looking forward to the follow-on activities from this. And we, as the Accelerator USAID funded program, would be happy to continue working with the ministry to get this through. So, we want to thank everyone, the residents who have joined. I hope that they are learning a lot. And also the fact that when we are in medical school, we are not trained. Apart from being doctors, we don't know much. All these are coming out now that we have to leave the sector. So a lot has been said, and we'll be very happy to continue working with. And I want to thank the backstage team for supporting us to participate online. Thank you all so much. God bless.
Thank you very much, Dr. Vanutu. So just had an update for us for our hits. We've had about 1,300 people visit the summit site. We had people from the US, from the UK, from China, from Canada, from France, Congo, Brazzaville, Switzerland, Germany, and Ethiopia. So I'm hoping that at the next summit, we will also start trending the statistics to see how we are doing year by year in terms of those who are joining us virtually. Like the Chief Director said, we've closed, but it looks like for the DPs and the government partners, we've not closed. So everybody else will be discharged with the exception of the DPs, and the government partners. I want to call on Pastor Samuel K. Boateng, Deputy Financial Controller, to give us the closing prayer.
Thank you. Shall we rise? O God, our help in ages past, you have graciously seen us through these 3 days of deliberations. Even as we engender further discussions and feed into the national discussions that will ensue, we beseech thee to continue to feed us with wisdom, knowledge, and understanding from on high. Give guidance and direction unto the things that we seek. May your mercies and your favor continue to envelop us as a nation, even as we seek your face to ensure that the laudable objectives that we have expounded come to pass. That thou mayest prosper and be in good health, even as thy soul prospers. I pray in Jesus' name. Amen.
Thank you very much, everybody. God richly bless you. So, our DPs and government partners kindly wait behind.
So please, like the MC said, the DP and government partners. So quickly, the good news is that we've all gone through the takeaway, so we agree on what should be on the agenda for the business meeting. Yes. So Christian, so project it so that we agree on what goes into the business meeting.
Alamini meli, takoban tazaghi.